Picture this. It's the early 1990s.
Right.
A patient comes into the emergency room with dangerously high blood pressure. I mean, they are in a full-blown hypertensive crisis.
Right, which is a massive red flag.
Exactly. So the standard protocol at the time was to literally hand the patient a liquid-filled capsule of a medication called nifedipine.
Yeah, the old bite and swallow method.
Yes. The doctor tells them to literally bite into the capsule, swallow the liquid, and the goal, was to drop the blood pressure instantly so they don't have a stroke.
Which logically sounds like what you'd want to do.
But instead, within minutes, the patient experiences a massive heart attack. Like the exact catastrophic event the doctor was trying to prevent in the first place.
Yeah, it was a complete medical backfire.
Mm-hmm.
And it fundamentally changed how we handle cardiovascular emergencies across the board.
It's crazy.
It really forced the entire medical community to rethink how we, manipulate the body's plumbing.
Well, welcome to the deep dive. Today, we're unpacking a massive stack of sources. We've got pharmacology textbooks, clinical trials, medical history notes, all to explore the medications at the very center of that backfire.
Calcium channel blocker.
Right, or CCBs. And whether you are a medical student, cramming to memorize drug classes for your board exams, or maybe you're just staring at an amlodipine prescription on your own nightstand right now.
Or if you're just insanely curious about human biology.
Exactly. Our mission today is to decode how these drugs actually manage to relax your blood vessels and slow your heart down.
Because to understand why biting into that pill caused a heart attack, we really first have to understand the microscopic machinery these drugs are targeting.
Okay, let's unpack this. Looking at the core definition from our sources, it says CCBs inhibit the influx of calcium ions through voltage-gated L-type calcium channels.
Right.
And this is in the plasma membrane of cardiac and vascular smooth muscle cells. But I'm looking really closely at that L-type designation. I mean, if there is an L-type, I'm assuming there's a whole alphabet of other channels we aren't even touching here.
There is, yeah. So L-type stands for long-lasting. And these specific channels are heavily concentrated in heart muscle and vascular smooth muscle.
Okay, so it's localized.
Very much so.
Yeah.
And this distinction is totally crucial, because if you take a CCB for blood pressure, you aren't significantly blocking, say, the T-type or N-type calcium channels.
What do those do?
Oh, they're busy doing things like firing neuronal signals up in your brain.
Oh, wow. Yeah, you wouldn't want to accidentally block your brain signals just to lower your blood pressure.
Exactly. So we are dealing with a very specific structural doorway in the cardiovascular system.
But, looking at the history in our notes, nobody just sat down in a lab and decided to build an L-type calcium channel blocker from scratch.
No, not at all.
Back in 1959, scientists didn't even know this cellular mechanism existed.
Right, it was a complete accident.
Yeah. Friedrich Haas and Ludwig Hartfelder, these two chemists at a German pharmaceutical company, Knoll AG, they were simply trying to synthesize a better drug to open up coronary blood vessels.
They were basically just tinkering.
Right. They created a cousin to an older drug called papaverine, and they named it verapamil.
And their hope was just for a simple vasodilator to treat angina. Chest pain.
But the clinical trials were weird, right?
Super weird. When they ran the trials, verapamil did relieve the chest pain, sure, but it also visibly weakened the contraction of the heart muscle.
Which is a negative inotropic effect, if I'm remembering the pharmacology term correctly.
Spot on. Yeah, a negative inotropic effect.
Which must have been completely baffling. I mean, if I'm a researcher in 1959 and I see a drug slowing the heart and weakening the squeeze, my mind goes straight to beta blockers.
Because that was the major cardiac discovery of the era. Most researchers assumed exactly that they had just stumbled onto another beta blocker.
But they hadn't.
No. And it took Ulbricht Fleckenstein, a German pharmacologist working at the University of Freiburg in the 60s, to figure it out.
He's the one who was doing the experiments on the isolated guinea pig hearts, right?
Yeah. Through this incredibly elegant series of experiments, he observed something really strange. The electrical signal telling the muscle to contract was still firing completely normally.
But the muscle wasn't squeezing.
Right. The muscle itself just wasn't responding. Verapamil was somehow uncoupling the electrical excitement from the mechanical contraction.
So the heart tissue was basically acting like it was bathed in a completely calcium-free solution, even though logically there was plenty of calcium in the room.
Exactly.
Now wait. The sources note that Fleckenstein coined the term calcium antagonists to describe these drugs. And as someone who's taken a few biology classes, the word antagonist paints a very specific picture in my head.
Uh-oh. I know where this is going.
Right. It sounds like the drug is physically out there hunting down calcium molecules in the blood and wrestling them to the ground, like an antibody neutralizing a virus.
Yeah, and that is a classic student trap.
Really, so it doesn't fight the calcium.
Not even a little bit. The drugs do not touch the calcium molecules at all. They don't chelate them or bind to them in the bloodstream.
Okay, so what are they actually doing then?
Well, this is why modern pharmacology strongly prefers the term calcium channel blocker. You have to think of the cell membrane as a thick, concrete wall, right?
Oh, okay. Got the wall.
And the channel protein is a doorway in that wall. The drug is simply a wedge that gets shoved under the door.
Ah, so it just blocks the path.
Exactly. It physically occupies the channel pore. So the calcium, which is just floating around outside minding its own business, simply can't get in.
Okay, but to see why wedging that door shut actually causes the heart to slow down, we really need to trace what that calcium normally does once it gets inside.
Right, the downstream effects.
And our sources draw this massive dividing line between how a heart cell handles calcium and how a blood vessel cell handles it. So let's look at the heart first. When that L-type doorway opens during a heartbeat's electrical pulse, the depolarization calcium rushes in. But the notes say that initial wave of extracellular calcium isn't strong enough to contract the whole muscle cell by itself.
No, it's really not. In the heart, it acts purely as a trigger.
Like pushing a domino.
Yeah, exactly. The heart cell relies on this mechanism called calcium-induced calcium release.
Okay.
So that small initial influx of calcium comes through the door and hits a massive storage vault inside the cell called the sarcoplasmic reticulum.
Wow, okay.
And hitting that vault forces it to dump a secondary massive flood of internal calcium.
And that massive flood is what binds to a specific protein called troponin C, which then forces the muscle fibers to slide together and actually contract.
Exactly. Plus, you have to remember, the heart's natural pacemakers, the SA and AV nodes, they rely heavily on this specific calcium current just to maintain their rhythmic firing.
Oh, right. So if you wedge the door shut with a CCB, you lose the trigger, which means you lose the massive internal flood. And so the heartbeat just naturally slows down and softens.
You got it. But if we cross over to the blood vessels, specifically the smooth muscle in your arteries, the architecture changes entirely.
How so?
Well, for starters, vascular smooth muscle lacks troponin completely.
Wait, completely? So it has to use a totally different operating system to contract.
Exactly. In the vessels, the calcium comes through the door, and instead of hitting a storage vault, it binds to a protein called calmodulin.
Calmodulin, okay.
Yeah, and this calcium calmodulin complex then activates an enzyme myosin light chain kinase, which finally gives the green light for the vessel to contract.
Okay, so if I'm visualizing this, the heart is basically a biological panic button.
I like that.
A little calcium comes in, hits the button, and dumps a huge bucket of internal calcium to create a powerful squeeze.
Right.
But the blood vessels operate on a much quieter sort of lock-and-key system with that calmodulin protein.
That's a great way to put it.
So does this mean we can target one without hitting the other? Because obviously sometimes you want to lower blood pressure without slowing the heart rate down.
Yes, and that is the exact foundation of the drug subclasses we use today. Because those cellular machineries are fundamentally different, pharmaceutical chemists realized they could exploit them.
Just by tweaking the shape of the drug.
Exactly. By tweaking the molecular shape of that chemical wedge, they could make it favor the L-type doors in the heart over the ones in the vessels, or vice versa.
Which brings us perfectly to the three main subclasses of CCBs. Basically the Goldilocks spectrum.
Yeah, let's dive into that.
Let's start with the drugs that aggressively target the lock-and-key system in the blood vessels, the dihydropyridines. If you're a listener looking at your own medication list, these are the ones that usually end in the suffix -ene.
Right. Amlodipine, nifedipine, felidipine.
So what's their deal?
These are highly selective for vascular smooth muscle. They basically wedge into those specific channels to forcefully dilate the arteries, which lowers blood pressure.
But what about the heart?
They have minimal direct effect on the heart's panic button, so they won't significantly slow down your heart rate.
Okay, so that's one end of the spectrum, the vessel relaxers. On the complete opposite end, heavily favoring the heart, we have the phenylacrylamines, which, looking at our notes, is basically just verapamil, our old friend from 1959.
Yep. Verapamil is pretty much in a class of its own here. It is heavily cardioselective.
Meaning it goes straight for the heart.
Exactly. It binds preferentially to cardiac tissue, It slows the electrical conduction right through the AV node and weakens the contraction.
And it's really good at that, isn't it?
Oh, it's so effective that it doubles as a Class 4 antiarrhythmic drug. It's used specifically in emergency settings to control dangerously fast heart rhythms.
Wow. Okay, so we have the vessel relaxers on one side, the heart slowers on the other. Sitting right in the middle of this spectrum, we have the benzodiazepines, mainly diltiazem, right? Developed in Japan in the 1970s.
That's the one. Diltiazem offers a really nice balance. It provides meaningful vasodilation in the arteries and meaningful cardiac depression in the heart.
So it's the middle ground. It gives a gentler side effect profile because it's not pushing too hard in just one direction.
It sits perfectly in the middle of that spectrum.
And the reason this spectrum matters to you, the listener, is because millions of people take these drugs daily. I mean, amlodipine is routinely one of the most prescribed medications in the whole world.
Oh, absolutely.
But you cannot treat calcium channel blocker as some generic umbrella term. Swapping amlodipine for verapamil is not like swapping Advil for generic ibuprofen.
No, it's not.
It fundamentally changes which organ you are targeting.
And choosing the wrong target can be totally disastrous.
Yeah, the notes have some wild examples of this.
The medical community really had to learn this the hard way regarding long-term clinical outcomes. The ALHAT trial in 2002 is a perfect historical example of this.
Okay, remind me of the setup for ALHAT.
Right, so researchers took over 33,000 high-risk hypertensive patients, and they compared amlodipine directly against a standard diuretic, chlorthalidone.
And according to the data, both drugs lowered blood pressure equally well on the monitors.
They did?
They also prevented coronary events like heart attacks just as effectively.
Yep, but here is where it gets really interesting.
Okay.
The trial found that patients on amlodipine had a significantly higher rate of developing heart failure compared to those on the diuretic.
See, I was trying to work out the math on this while reading the notes, and it felt backwards.
How so?
Well, if both drugs lower the blood pressure reading on the monitor to the exact same number, why is the heart failing more often with the CCB? I mean, a lower pressure should mean less work for the heart, right?
It definitely seems contradictory at first, but you have to look at how they actually achieve that lower number. It all comes down to volume.
Volume of blood.
Yes. Amlodipine works by relaxing the pipes. It dilates the blood vessels, but it doesn't actually remove any fluid from the body.
Ah.
A diuretic, on the other hand, forces the kidneys to excrete sodium and water. It physically reduces the total volume of blood the heart has to pump.
Okay, so for patients who are already on the brink of heart failure.
Right. For them, just widening the pipes wasn't enough. Their weakened hearts still struggled against the massive total volume of fluid circulating in the system, which eventually led to failure.
So the diuretic actually lowered the workload by lowering the total volume.
Exactly.
That is a brutal reminder that treating a number on a chart is just not the same as treating the underlying physics of the patient's body.
It's a huge lesson.
But, that's a long-term chronic issue. Our sources also outline some immediate catastrophic scenarios if you mix up these subclasses, specifically the Wolff-Parkinson-White, or WPW syndrome trap.
Oh, yeah, this is a terrifying real-world exam scenario that actually happens.
Just break it down for us.
Imagine a patient comes into the ER with atrial fibrillation. The top chambers of their heart are beating wildly, just sending rapid, chaotic electrical signals down to the ventricles.
And your first instinct as a doctor might be to give them verapamil, our heart-slowing CCB, right? To block the AV node and slow down all that crazy electrical traffic.
It seems logical, but WPW means the patient has a rogue accessory electrical pathway in their heart.
Okay, so if the normal AV node is a highly regulated highway toll booth, this accessory pathway is like an unregulated dirt road that completely bypasses that toll booth.
That's a perfect analogy. So if I push verapamil into their 4V, I'm essentially dropping a massive concrete barrier on the main toll booth.
Because verapamil strongly blocks the AV node.
Right. And electricity always takes the path of least resistance.
Wait, so instead of stopping those chaotic signals, the verapamil forces all of them to just speed down that uninhibited dirt road.
Yes. They bypass the toll booth, speed down the dirt road, and crash directly into the ventricles all at once.
Oh my God.
Yeah, it sends the heart into a lethal spasm ventricular fibrillation.
So you used the right class of drug, but for the wrong anatomy, and inadvertently caused a fatal arrhythmia.
Exactly. Which actually ties perfectly back to your opening story about biting into the nifedipine capsule back in the 90s.
Oh, right. The 1995 nifedipine scare.
Yeah, that was another case of fundamentally misunderstanding the body's holistic systemic response.
Because physician researcher Bruce Sadie, he published those explosive findings in JAMA, right?
He did.
He showed that taking that short-acting nifedipine capsule caused the blood pressure to drop off a cliff instantly. But I guess the body doesn't just passively accept a cliff dive and blood pressure, does it?
Definitely not. The nervous system senses that massive, sudden drop, and it panics. It literally assumes you are bleeding out.
Oh, wow.
So it triggers a massive reflex sympathetic activation, just a huge surge of adrenaline.
It slams on the gas pedal, the heart rate shoots up, which the notes call reflex tachycardia, trying desperately to pump the pressure back up to survive.
Right. Now, imagine if that patient already has compromised, clogged coronary arteries.
Oh, no.
Suddenly forcing their heart to sprint a marathon and nowhere starves it of oxygen. It triggers myocardial ischemia, resulting in the exact heart attack the doctor was trying to prevent in the first place.
That is wild. And that revelation forced the whole medical world to shift away from immediate release dihydropyridines.
Thank goodness. Today we rely heavily on long-acting, slow-onset formulations.
Because you want to ease the pressure down on a gentle slope.
Right, so the body's alarm systems don't wake up and panic.
Makes total sense. But, even when we do it slowly and correctly, with a daily pill like amlodipine, manipulating this plumbing creates a totally different set of physical traffic jams.
Oh, you mean the ankle swelling?
Yeah. One of the most common complaints patients have on amlodipine is peripheral edema swollen ankles.
And it routinely leads to the wrong treatment. If we connect this to the bigger picture, a patient comes in complaining of swollen ankles, and the immediate instinct for many clinicians is to prescribe a diuretic.
To help them pee out the extra fluid, because we just naturally assume it's fluid overload.
Right, but the sources point out this is actually a Starling forces problem.
Okay, if I remember my physiology classes, Starling forces are all about the tug-of-war of pressures inside our blood vessels. You have hydrostatic pressure pushing fluid out of the vessel, and oncotic pressure pulling it back in.
And that tug-of-war is the absolute key to this whole side effect, because CCBs, specifically the dipines, are incredibly potent dilators of the arterioles.
Which are the small arteries feeding blood into the tissues.
Exactly, but they have almost no effect whatsoever on the venules.
The veins draining blood out of the tissues.
Oh.
So wait, you have a massive wide-open pipe blasting blood into the capillary bed, but a tight, narrow pipe trying to drain it out.
Yes. So the hydrostatic pressure inside the capillary just skyrockets. And that physical force pushes fluid through the vessel walls straight into the surrounding tissue of the ankles.
So the patient isn't fluid overloaded at all?
Not at all. The total volume of water in their body is perfectly fine. The fluid is just pooled in the wrong place because of a localized pressure mismatch.
Ah.
So if you give a diuretic, you end up dehydrating the patient and reducing their overall blood volume, but you haven't fixed the local traffic jam at the ankles.
Wow, so how do you fix it then?
To fix it, you need to either lower the CCB dose or add a drug like an ACE inhibitor, which actually dilates the veins.
Oh, so you open up the drainage pipe to match the inflow pipe.
Exactly, and the pressure normalizes. It's purely an issue of biological plumbing.
That is brilliant. Okay, speaking of unexpected biological interactions, I have to bring up the happy hour accident of 1991.
Oh, this is a classic story.
We've all seen the warning sticker on our pill bottles, right? Do not take with grapefruit juice. For years, I just figured it was an acidity thing, like maybe the acid would dissolve the pill too fast in your stomach.
Oh, the actual mechanism is far more intricate than that. And its discovery was entirely accidental.
Yeah, a Canadian researcher, David Bailey, he was studying how the CCB amlodipine interacted with alcohol.
Right. And to run a proper double-blind study, he had to mask the taste of the alcohol so the subjects wouldn't know what they were drinking.
So he mixes it with grapefruit juice.
Just to hide the booze, yeah.
Right. And he ends up discovering that the blood levels of amlodipine in his subjects somehow shot up to toxic levels. And it turned out the alcohol had nothing to do with it. It was the juice.
It was the juice, because grapefruit juice contains specific organic compounds called furanocoumarins.
Furanocoumarins.
Yeah. And these compounds, they don't interact with the drug itself in the cup. Instead, they irreversibly inhibit an enzyme in the wall of your small intestine called CYP3A4.
Okay, CYP3A4 is basically the bouncer at the club, right?
I love that, yes.
Its job is to break down a large portion of the drug, what pharmacology notes call first-pass metabolism, before the drug ever reaches your systemic circulation.
Yep, it's a key regulator of how much drug actually makes it into your bloodstream.
But those pharmacoumarins in the grapefruit juice take the bouncer completely out of commission.
Just knocks them out. And without that enzyme breaking the drug down during absorption, a massive, unmitigated dose floods into the bloodstream all at once.
Which leads to dangerous hypotension, a massive drop in blood pressure.
Exactly. What started as just a clever lab trick to hide the taste of booze resulted in a global pharmacological warning label.
That is just mind-blowing. So pulling all these threads together, what have we actually learned from all these sources today?
Well, I think the main takeaway is that calcium channel blockers are incredible nuanced tools, but they require precision.
Right, they don't just wrestle calcium in the blood, they act as physical wedges in the L-type doorways of our cells.
And you absolutely have to respect the subclasses.
Because verapamil wedges the doors in the heart. Nifedipine wedges the doors in the blood vessels. And diltiazem does a little bit of both.
Exactly. You cannot blindly swap them. You shouldn't mix the heart-slowing ones with beta blockers. A diuretic definitely won't fix amlodipine-induced ankle swelling. And equal blood pressure reduction on a monitor doesn't always equal heart health.
Yeah, that all-hat trial really drives that home. But as we wrap up, there was one detail in the clinical notes that I keep coming back to.
What's
Well, we focus so heavily on blood pressure and heart rates when we talk about these drugs. But the sources mention that amlodipine, which is a very specific CCB, is used uniquely to prevent blood vessel spasms in the brain after a hemorrhage.
Oh, right.
And verapamil is sometimes prescribed to prevent cluster headaches.
Yeah, which leaves us with a really fascinating thought to chew on.
All right.
If voltage-gated calcium channels are so fundamental to such diverse tissues, I mean, from the arteries in our legs to the pacing nodes of our hearts to the complex vasculature of our brains, what other unexplored physiological pathways might these targeted door blockers unlock in the future?
It makes you wonder.
We are likely only scratching the surface of what manipulating these cellular doorways can achieve in modern medicine.
It turns out there's just no such thing as a simple light switch in the human body. Just millions of doors waiting for the exact right key.
Perfectly said.
Well, thanks for joining us on this deep dive into the hidden mechanics of your medical sources. Stay curious, and we'll catch you next time.